This little videotape is on different things to think about when facilitating movement. First and foremost, you always want to look at a patient's base of support and their alignment. You always want to start with that. So if I want Mrs. Jackson to stand up for us, I want to look at how she is. Now she's way far back in the chair, so I'd want her to scoot forward first. And I also see that her feet are way out in front of her. I'd want them to be underneath her so that they provide a good base of support under which she can stand on. All right, so first I would ask her to do it herself. I'm not going to give a lot of instructions and tell her how to scoot forward, but I'd ask my patient, can you scoot forward in that chair for me? All right. She chooses a little bit of a cheat method. We're going to work on that in the future where she pushes off the back of the chair to slide forward. And then I want to look at her alignment. She shifted to the right and her left leg is out in front. Can you fix your left leg for me? She's got some of it. I'm going to give her a little bit of help. All right. There you go. Now I'm looking again at her alignment. She looks more symmetrically aligned, but I think at 90, if we can tuck one foot back a little bit further, it's going to be easier to stand up. And when it comes to that, the leg you push further back is the one that's going to do more of the work. So if I want her left side, her weaker side, to do more of the work, I would have her tuck the left leg back even further. All right? So there we have it. All right, now I want you to be able to push up into standing. I talk about points of control in my lecture. There are different ways of adjusting your points of control, either proximally or distally. Different patients require different amounts of assistance when they stand up, or different amounts of facilitation. So there are some patients that, yes, I have to get really close to and under their ischial tuberosities and help them into standing. And there's others that do not require nearly as much facilitation. All right, and that may be merely putting their hands into my hand, okay, and just guiding them forward to stand up. That would be a distal point of control in order to stand up. More proximally could be at the pelvis where I'm behind them. And as a therapist, I use my forearm an awful lot. So here, I'm around her, I'm guiding her forward, okay, and I'm using my forearm to do a lot of the work that I need. My forearm is bringing her forward. Sometimes, as a patient progresses, they may only need facilitation from here, or put my hands on their shoulder blades, bring them forward, and they can stand up. So depending on what your patient needs is going to be where your hands are and how you facilitate. So you work with your patient and you figure out what works best for the patient. Everybody's different, so there's more than one way to skin a cat. Alrighty? So to complete this sit-to-stand transfer, if I didn't know anything about the patient, I may be more inclined to be in front of them because I don't know how well they're going to do. But in this case, I know a little bit about Miss Jackson, so I'm going to be behind her, all right, bringing her forward. I'm going to ask her to push up with both arms because you want to incorporate, even if this is the weaker arm, you want forward, and she wants to tuck that right leg back, using my forearm, bringing forward, protecting with my hand, well, not protecting, but guarding with my hand. I'm able to upright her when she needs it, and I'm right in the position to guard for gait training.